Hôm nay trong cái chương trình gọi là học hỏi của chúng ta, tôi sẽ trình bày với quý vị cái đề tài về viêm gan C ở người Việt Nam tại đây. 5 năm trước chúng ta nói về bệnh viêm gan B là một cái bệnh rất là thông thường ở người dân Việt Nam. Thì gần đây chúng tôi thấy viêm gan C là hepatitis C cũng rất là thịnh hành. Đặc biệt là những người dân ở trong cái quận cam này hoặc trong cái tiểu bang California hoặc là xứ Mỹ thì sẽ có rất là nhiều người bị cái đó. Cho nên tôi quên không có chiếu cái hình cái này lên để là chào mừng giáo sư Đào Hữu Anh và phu nhân, chào mừng giáo sư Nguyễn Nhất Thống và phu nhân, và đặc biệt giáo sư Nguyễn Thị Nhược. Xin cảm ơn thầy cô rất là nhiều. Buổi nói chuyện ngày hôm nay sẽ nói về chronic hepatitis C in Vietnamese Americans. I am a consultant in gastroenterology and hepatology in Fountain Valley, California. And I would like to take this opportunity to thank California Specialty Pharmacy, our proud sponsor of tonight's program. Thank you. There is some health disparity among the Vietnamese American because we are a different kind of people. We came from abroad. We immigrated here about 42 years ago. And I can show you that there are a lot of disparity in terms of hypertension, in terms of cerebrovascular accident, which is stroke, diabetes, extremely high in our patient population. But there's also a high prevalence of hepatitis B, and the prevalence among the communities around here is 8.8%. But at the last survey that we did, it was 13.6%. So 13.6% of Vietnamese Americans living in the United States tested positive for hepatitis B. Contrast that with the Vietnamese in Vietnam, the rate is 20%, extremely high. For every 5 people walking the street of Ho Chi Minh City or Hanoi, 1 tested positive for hepatitis B. However, for hepatitis C, around here it varies between 5.8% to about 15%. So for every 12 Vietnamese Americans living in the United States, 1 has hepatitis C. And due to the Vietnam War veterans from both the US and the Vietnam who have high rate of hepatitis C infection, ranging from 10 to 20%. And that was attributed to the fact that some of them did use drugs during the wartime. They had blood contact during combat, during surgery, transfusion, and sometimes through sexual transmission. So the reuse of needle and syringes and blood transfusion before 1992 are major contributors to the spreading of the disease. Why 1992? Just because this is the time when we developed an assay to detect hepatitis C in the blood. The virus used to be called non-A, non-B hepatitis virus because we don't have a name for it. But now we know that it is hepatitis hepatitis C, identified in 1988. And so far, there's no vaccine against hepatitis B, hepatitis C. We have hepatitis A vaccination, we have B, but we do not have hepatitis C vaccination yet. And it is the most common chronic blood-borne infection in this country. And because of that, the progression of the disease is very slow, going from a healthy liver, untreated, going to lead to fibrotic liver, and finally a cirrhotic liver. There's one missing picture out here, which is liver cancer. So having chronic hepatitis C and you leave it untreated, then obviously the resulting will be hepatocellular carcinoma or liver cancer. Most of the time, the disease does not have any symptoms and will progress to serious complication within decades and without us knowing about it. So therefore, most of the patients are asymptomatic until serious liver complications arise. So this is a Very difficult situation when patients only come to see us when they are symptomatic. You never come to go see a doctor if you don't have any pain, if you don't have any fever, if you don't have any diarrhea. But patients with chronic hepatitis C do not have any symptoms. And by the time they present to our office for evaluation, probably they already have either liver cirrhosis or liver fibrosis, worse yet, liver cancer. This is the problem in this country. I mean, it reflects the fact that there are 3.5 million people with hepatitis C. But how many of those are diagnosed with the disease? Only half, 1.7 million. And how many of those come into our office to receive treatment? Less than 10%. So I always say to my colleagues around here that as healthcare providers or doctors or physicians, we are doing a very bad job at taking care of our patient, because from 100% infected, and we only treat 10% of them, not even. So there's a lot of people out there walking the street at Bosa, and nobody has touched them because we did not go there and find them. So your role in the management of this disease is very important. As a doctor, and you take this message home and try to help your own people, I think this is a very strong thing that I would like to convey to you tonight. How are we going to do about that? We screen. Screening means looking for patients with the disease. If you don't look, you ain't find it. You have to find those, and the way that you find it will be through screening. It's very simple. A simple blood test looking for anti-HCV antibody will show you whether that patient has the disease or not. Very simple, just a little stick, no big deal, all right? And that's how you detect HCV antibodies. He looks familiar. So whom should we screen? There are people that we have to screen. We don't screen everybody. So we call them the at-risk patients. Those who show you or told you that they have injected drug, IV drug, even once in their life. It doesn't have to be habitual IV drug user, only once. Then that predisposes them to have hepatitis C. Anybody who do intranasal illicit drug use, cocaine, and they walk the white line, we call that, and they sniff it like this, that also predisposes them to have hepatitis C. Anybody who are on long-term hemodialysis, chronic kidney disease patient on hemodialysis, they are at risk. Anybody getting a tattoo in an unregulated setting, that means at home, from friends, or from a swap meet, right? They didn't go to a tattoo parlor to do it, so therefore they are at risk. Incarcerated person, people who are left in prison, and you know what they do? They have a lot of time, so they always trying to manage to stick themselves with dirty needles or dirty sharp object. Healthcare workers, just like ourselves, we are at risk because you take care of patient day in and day out. We expose ourselves to blood and at risk, and therefore we put ourselves at risk for having hepatitis C. Children born to infected women, because it could be transmitted from mother to children. Recipient of any clotting factor concentrator produced before 1987, or anybody receiving blood transfusion before July 1992. That's the time when we have an assay to detect hepatitis C virus. HIV infection, why? Because the mode of transmission between the two viruses are about the same, through blood. And anybody who has unexplained, persistently elevated ALT, which is liver enzyme, you just cannot attribute to tobacco, cannot attribute to other stuff, but you have to look and find whether they have hepatitis C infection or not. This is a IV drug abuser, right? So when you see needle track in their arm, when you examine them, they are at risk. This is a patient of mine, he's got in the concentration camp, and somebody else did this to him in the camp. And you know how they did it? Very sharp metal object, not even a needle, nothing. So he came to me with this kind of tattoo. So therefore, that will give you the suspicion that he might have hepatitis C. Same person, right? On the left side, the picture of a woman, And on the right side, I'm pretty sure that he aspired to be a physician. While in concentrate camp, he wanted to be a doctor. So he studied spermatozoa. So he has this tattoo on his thigh. So when he get out of camp, he said, well, I want to be something like, histology, doing pathology, like Dr. Dao. This is tattoo, okay? These are done professionally. This is my name. This is my name in Chinese character. I just wish that this is my tummy. Mine is not that flat. This is not a tattoo applied professionally, but again, when you see a lot of tattoo on the patient's body, you have to be careful. The other thing that the same patient of mine with a tattoo in the back, and these are called cupping. Yeah, very common in our patient population. If you don't feel well, then they're gonna lay you down and then apply those really hot glass cup on you and suck all the plasma out of your. And this is even worse, right? Body piercing. And this is, I don't know I cannot imagine somebody to put these through the nipple. That hurts. I wouldn't let them do it. So bleeding from the tongue, around the lips, and around, this is about the navel. So all these are predisposing factors, putting that patient at risk for hepatitis C infection. Here's another one, cupping. And this is commonly done in our country, Vietnam. And when you go to Thailand, wow, this is very common, all right? Even Caucasian travelers to Thailand or Bangkok, they love this. They didn't know that they may be at risk for hepatitis C. Even Olympians, you know who that is? Michael Phelps, all right? The most decorated, Olympic medalist. And look at what happened to him. Boom, boom, boom. He had these things before he ran for his last competition. And this became a winner. So perhaps anybody who wants to be a gold medalist at swimming competition in the Olympics, you better do those little cupping. That helps, I think. And this is gao yao, right? We love it, right? And the redder it is, the harder it is. By the way, this is my back, right? So I received it on the day when I got home. I got too tired, and my wife would say, "Honey, lay down, please." Right? I say, well, she would do something, massage, and then I turn around. This is what I got: severe gout, y'all. And when you do that, the more you bleed, the better it's going to be. Right? So therefore, you have to suffer. Cannot say anything. Your wife doing it, right? So you have to you shut your mouth, and then you just suffer. Beside the risk factors, there is something new that the CDC had reported a few years ago, and that is being a baby boomer. That means anybody born between the age of 1945 and 1965, that's most of us around here, we are predisposed to have hepatitis C. So all the clinics around here are supposed to screen patients between these birth ages because of their birth age. Regardless whether they have risk factors or not, we still have to screen them because they account for 75% of all the hepatitis C infection in this country. That is significant. 3 out of 4 got infected if they were born between 1945 and 1965. There's some problem with our Vietnamese Americans in this country because there's some barrier. How come they didn't come to see the doctor for treatment? Because even though they have insurance, only half of them will seek medical care. For some reason, we don't know, but I believe that there is, years ago, there's a stigma. That means if you have hepatitis C, that is associated with sexually transmitted disease. And you don't want to disclose that to your doctor, otherwise say, you've been messing around a lot, right? That's why you got hepatitis C. No longer true. So therefore, they kind of hide it from the doctor. Even if we ask them a question, they will say no. So 50% of them did not get medical attention. And even if they have any kind of care, 30% of them only seek active care. So therefore, we have a problem bringing our own people into the clinic for treatment or even for screening. So once you have screened them, then, and you find those patients have hepatitis C infection, the next test you would want to do is an HCV RNA, which is the test looking for the viruses in your patient's plasma. And this is called a viral load. I need to know how high or how low the viral load is before you decide on treating those patients. So the next test will be before, after you have the HCV antibodies. If it is negative, your patient does not have it. But if they tested positive, they are either exposed or they already have the disease, then you move on to the next test, which is HCV RNA testing, counting the number of viruses. And if it is positive, then you should refer the patient to a specialist for treatment. To make the diagnosis of hepatitis C infection, number one, positive HCV antibodies. Number two, detectable HCV RNA. Because once you have that diagnosis confirmed, you have to send it to the specialist. Do not wait for the viral load to go up. Do not wait for there is any liver function test, because these may be normal in a lot of patients who have the disease. So therefore, do not wait until you see anything unusual about the liver function test before referring them out. Because this disease progresses very silently, right, without any symptoms until they have complications. There's a good piece of information is that it is curable. That means we can cure it. So in the past, when we went to medical school, the traditional teaching has been viral disease will never be cured. It is true for hepatitis B, but it is no longer true for hepatitis C, because now we can cure it. Why? Because the genome, the genetic components of the virus stay outside of the liver nucleus. So if it is outside the nucleus, then the medication can penetrate into the liver cell cytoplasm and disrupt the transcription or the replication of the viruses. If you contrast that with hepatitis B infection, the genomic component is inside, it is in the nucleus, so therefore we don't have any medication to penetrate into the nucleus to disrupt this process. But because hepatitis C has in the cytoplasm, therefore we're able to do that. And same thing for HIV, is incorporated with the liver cells, the genome. So therefore we couldn't treat hepatitis B infection, and we have not yet cured HIV. Only HCV now is treatable and curable. So if you want to mention about cure, you have to determine what we call SVR12. That means sustained virological response 12 weeks after you stop the treatment. Once we put the patient on medication, the viral load, which is HCV RNA, gonna drop to undetectable. And when you stop the treatment, 12 weeks after that, it should remain undetectable. So where it is become undetectable 12 weeks after you end the treatment, that is called cure. So cure means undetectable 12 weeks after you stop the treatment. Hepatitis C also is divided into different genotypes. And in our country of Vietnam, genotype number 6 is the most common. Number 6 genotype, and also genotype 1, 2, and 3. In America, most of our American patients, test genotype 1 or 2. But in Vietnam, a lot, and besides I practice in the Vietnamese community, many of my patients have genotype 6. Just give you a perspective on how far you have come along from treating with this kind of problem. I started treating hepatitis C in about 1990. So in 1990, we have very bad medication because those medications gave patients a lot of side effects. So in 2001, we used PEG interferon, which is injectable, with ribavirin, which is pill. So patients will have to take injectable and pill almost every day for a response of about 40 to 50%. So half of the patient will respond, and most of them will have to suffer because of the side effects of the medication. In 2011, we have a new generation of medication, but they still have to use a lot of pills and continue to give themselves injection. Even though the SVR, that means the response rate is much better, from 70 to 75%, but it's still not the best. And recently, 2014, we have the newer class of medication. No injection, only 1 pill a day. And we achieve an SVR of 97%. And you look at it, we went from 40% 16 years ago, and now we treat almost 100% of patients with only 1 pill a day. No injection, no side effects, no nothing. So just show you we have come a long way. And this is, I call, thuốc tiên, thần dược, magic drug. That's what we have now for our patient. So therefore, that's the patient say, well, I don't want to have any side effects on the medication. You can tell them, no side effects, nothing to worry about, 1 pill a day. How much does it cost? Very cheap, $1,000 per pill. So with that much money, we cure 97% of our patients. So which is incredible. When I start treating these patients 20 years ago, I say, I would never get to see 60%, 70%. And now we are seeing 97%, and it is approaching 100%. We are hoping that we can eradicate hepatitis C out of this earth by 2030. It can be cured. So the message I want you to take back to your patient is that hepatitis C is curable. Not like hypertension or diabetes. These are manageable. You manage them, but you cannot cure hypertension. You cannot cure diabetes. But for HCV infection, it is curable. I can assure you that is true. Because if we cure them, look, the rate of complication and the mortality associated with the infection is much less. Patients who achieve SVR cure, the rate of mortality is much lower than people who did not get SVR and infection with cure. So therefore, the message to take home is that with SVR, with cure, HCV infection, we can prevent progression of the disease to liver cancer, liver cirrhosis. And in the next few years or so, we'll be seeing more cases of liver cancer, hepatocellular carcinoma, and we'll be seeing more patients with decompensated cirrhosis, because this is the time they got infected maybe 20, 30 years ago, and they let the disease progress. So in my practice, I've been seeing more and more patients with severe disease. Cirrhotic patients who have ascites, who have peripheral edema, who is encephalopathic, because they wait until they get to the end stage of their disease to come to see us. And more, we are sending more patients for liver transplantation because of the high rise in liver cancer. So in summary, HCV is underdiagnosed, right? We haven't screened too many of our patients, and it is undertreated. So the message I want you to take home is to screen your patients, look for them. Anybody who has risk factors, please do a blood test. Despite that, we still haven't reached like 20% of 30. We're only treating 10% of those patients. And remember that with the new medication, 1 pill a day, the disease is curable. No more hepatitis C. And your role in screening, diagnosing, and referring your patients out to specialists for treatment is extremely important. And for that, I would like to thank you, the Cancer Board from California Specialty Pharmacy, who had supported us in this presentation and tonight's dinner. Thank you. We have 2 minutes for questions. Yes.
Is hepatitis C across placenta? And if it does, why the OB and none of them screen for hepatitis C? They only screen for hepatitis B.
The question from our friend in the back is that, does the virus, the hepatitis C virus, cross the placenta? And how come the OB or the gynecologist never screen their pregnant patient for hepatitis C infection? And the answer is this. You have to contrast that with hepatitis B infection, because hepatitis B viruses crosses the placenta readily. If a pregnant woman at her late stage of pregnancy and she has a very high viral load, for example, 20 million copies of hepatitis B virus, at the time of delivery, it will cross to the placenta into the baby, and that's how most of our Vietnamese patients got infected at the time of birth. We call mother-to-child transmission or vertical transmission. That does not apply to hepatitis C because the rate of the transmission is less than 5% from mother to child, compared to 95% in hepatitis B infection. So because the rate of infection through maternal transmission is so low, we are not obligated to screen those pregnant women for hepatitis C infection.
On the newly diagnosed Hep C with the antibodies positive, the HCV virus is not infected, do you treat immediately or you wait?
The question is that if your patient tested positive for hepatitis C antibodies, and then you do the viral load, HCV RNA, and it is undetectable, do we treat them or not? I would say no, because there's nothing for me to treat. I need to see viruses in order to eradicate them. Remember that HCV antibodies could be false positive. So that's why when you have a positive HCV antibody during the screening period, and that patient is not at risk, that patient is not a baby boomer, and you want to verify, to confirm it, you do HCV RNA looking for viral load. But if the viral is undetectable, that could be a false positive HCV antibodies. We see that commonly in immunosuppressed patients. Patients who are HIV infected, chronic kidney disease patient on hemodialysis, rheumatoid arthritis patient, cancer patient on immunotherapy or chemotherapy. That could be a false positive.
So in this case, I don't need to.
Yeah, if you do not detect HCV RNA, you don't need to treat. In my practice, I follow them up every 6 months.
So that means I don't need to refer them to you?
You don't have to. Yeah, no referral because we don't do anything. If you refer patients to us.
What is the risk of a person who had coughing or spooning or EMG? And how long do we do the test to check out when with the possibility of a positive test?
Say that again, please. I'll give you the microphone.
What is the percentage of people who had coughing or spooning or EMG contract hepatitis C? Second thing is, when will be the best time to test it?
The question is about cupping and having all those like coining. What the percentage of patients who are going to get the disease, I do not have a number. Yeah, we don't have any because our patient population around here is so small. There's no survey to see whether the patient will get infected through cupping or coining. So, answer to that question, I do not have an answer. And how often do we screen them? So, if they are still at risk, that means if they say, well, you continue to have cupping every week or so, then you continue to screen them. If they come in, usually they don't come to see you on a monthly basis, but every time if they come in for diabetes management or blood pressure management, then we do screen them along with their regular blood test. I was just at HCV antibodies, and sometimes to your surprise, they tested positive. So they continue to be at risk if they continue to like use drug or or cupping, so on and so forth. from, yeah.
How can the patient can afford the medical medication? How can they afford it? Because it's so expensive.
The question is about money. How can patients afford the cost of the medication? I told you it's $1,000 a pill. That was 3 years ago. And now with more competition, it has dropped to a little bit to maybe $930. And now recently, maybe more product coming into the market is gonna be just like anybody else. If you have a lot of competition, then you have to drop your price, otherwise nobody's gonna buy your product. But so far, I haven't seen anything less than $75,000 for a course of treatment, which is 12 weeks. Usually when we treat these patients, we put them on medication, 1 pill a day for 12 weeks. That's 84 pills. And it usually costs insurance $75,000. So it is expensive. So therefore, likely we're gonna be having more and more patients who could not afford it because the insurance won't pay for it. But we are hoping that in the future, more products are gonna come out into the market, and because of the competition, they may drop their medication a little bit further, but I don't think it's gonna be that much. See, in one of the presentations, one of the doctors asked me, how come it is so expensive in America? Because she knew the same medicine in Egypt will cost the patient $1,000. So why $100,000 here in the USA? Anybody knows? Let me tell you. Because thanks to the lawyers. That's it. If you have a product, God forbid, if something goes wrong with it, that product, 100,000 people are gonna sue the heck out of you. How you can defend yourself? You have to have a good money in your bank. Hire good lawyers to defend you. Hey, welcome to healthcare in America. So with that, I think the next item would be, go on.